Hello everybody, this is Dr. Tyler Evans from Herniated Chiropractic coming at you live. It's late tonight, but I wanted to get this video out for our Dinner with Doc that's coming up on February 20th at Atlantic Grill in Rye, New Hampshire. That's at 6:30 on a Thursday night. And what we're talking about is neck pain. And we will be sharing that night with a friend of ours, Carrie Jose from CJPT. And we'll be talking about some of the diagnoses and how the neck works and why chronic neck pain exists and some things to do about it. But tonight I just wanted to share with you some of the stats out of a paper that came out in 2015. It's from the Mayo Clinic. Stephen Cohen, he's an MD. He went through all the literature on neck pain, did a kind of a review of the problem. It's called Epidemiology, Diagnosis, and Treatment of Neck Pain. It was at the Symposium on Pain Medicine. Anyways, so in this paper, what they talk about it, and this is the title of the paper here. In this paper, what they talk about is that neck pain is the fourth leading cause of disability with an annual prevalence rate exceeding 30%. Most episodes of acute neck pain will resolve with or without treatment, but nearly 50% of individuals will continue to experience some degree of pain or frequent occurrences. So it affects a lot of people, basically, and not too many people get away without a bout of neck pain at some point in their life. And it basically just, it says that patients that suffer from neck pain, there's a lot of treatments for it, but the outcomes aren't always great. And I want to walk through why some of that might be and what you can do about it. So overview of neck pain, or epidemiology, how it works. So according to a global burden disease study, 2010 study, neck pain is the fourth leading cause of years lost to disability, ranking behind back pain, depression, and arthralgias, which are arthritis. And approximately half of all individuals will experience a clinically important neck pain episode over the course of their lifetime. So there's substantial heterogeneity in the reported prevalence rates of neck pain. However, most studies report an annual prevalence between 15 and 50%, with the average of like 37%. So 30% of people annually get neck pain. So the interesting, not cool, but the interesting stat here is that prevalence of neck pain is higher in females and peaks around middle age. And we see that in our practice. So a lot of the time, the people that call in are women, middle age, that have had either a car accident or that have sit at desks and work at computers for long periods of time. It's just a chronic thing that we see. There's lots of reasons for that. One of them is that women's necks tend to be a little bit thinner and have less structure to hold or less soft tissue to hold the structure up. And so therefore in accidents and injuries, we see more chronic problems result from that. So unique risk factors for neck pain include trauma, traumatic brain injury, whiplash injuries, certain sports injuries, including wrestling, ice hockey, football. Although certain occupations such as office and computer workers, manual laborers, and healthcare workers have been found in some studies to have a higher incidence of neck pain, the major workplace factors associated with the condition are low job satisfaction and perceived poor workplace environment, which is really interesting because it goes to more of the psychosocial part of it. And, stress creates pain in the body. The body is a scrapbook, and so stress can do that to the body. And so, working on stress relief is a big part of managing pain in your life. So most common examples of peripheral neuropathic pain are radicular symptoms from a herniated disc or an osteophyte, which is basically like a big gnarly piece of bone that's growing off in arthritis. And that arises, differentiating neuropathic from mechanical pain. So neuropathic meaning it's neurological in origin, meaning it's actually like a nerve that's being affected, or it's the central spinal cord that's being affected rather than like a bone rubbing on a bone, or a muscle that's injured, or a ligament or a tendon that's injured. So differentiating that neurological pain from the mechanical pain is probably the most important clinical distinction to make, as it affects treatment decisions at every level. So we do that in our office. When someone comes in, we go through and we really evaluate how this patient presents in terms of level of pain, when they have it. Is it something that it's more in the morning? Is it more in the evening? Does it throb? Is it a sharp burn? Is it a radiating pain? So those types of things really matter, and they can determine how to best determine treatment going forward. And sometimes in our office, the mechanical patients, they do very well, and we see that the mechanical situations tend to relieve very quickly. We also see that the neurologic problems, they sometimes can go away very quickly as well, but sometimes the neurological problems can last a lot longer because it's a nerve that's being affected, and nerves take a minimum of 90 days to heal. They can take a lot longer than that if they will heal at all. So there's a lot of interesting little tidbits that unless you really understand where pain comes from and how it works, you're not going to be able to navigate the treatment options very well. So that's why getting a good history and diagnosis in a either medical practice or a chiropractic office is a really good way to start understanding what's going on, or physical therapy, so that you can move forward in a smart way. Okay, so natural course of neck pain. So similar to back pain, most cases of acute neck pain will resolve to a large extent within 2 months, but close to 50% of patients will continue to have some pain or frequent recurrences 1 year after the initial occurrence. No association was found between the degree of radiographic degeneration and satisfaction with treatment results. So this is something we see in our practice quite often. We have patients that come in that are literally like 5 years old, and they have neck pain, and they have migraines, and they have headaches, and their structure in their neck may look somewhat normal. Oftentimes to us, there are very small differences that we're looking for in terms of when we take an x-ray to see the structure of the bones. But there are also patients that come in that are 90 years old, and they have degeneration in their neck, and we get them adjusted, and alignment comes back to the neck, and voila, they feel a ton better, and it's not a limiting factor, that degeneration. So degeneration is not always a good predictor, or arthritis is not always a good predictor for outcome. So just because there's arthritis doesn't mean that neck pain has to persist. It's just we want to manage that, and it's good to know that you have those things. So it's just like a dentist. When you go to the dentist, they always take x-rays, or they usually say, hey, look, it's really important that we take x-rays, because they want to see what's going on in there and really give you a good look inside. And that's the same thing with chiropractic. It's the same thing with medicine. It's really important that we look inside and see what's going on, not just go through the history and maybe feel what's going on in there. We have patients that come in that are very young, very old, and all the way in between. And the x-ray does tell us a lot of information, but the findings on the x-ray, they're not the only thing, okay? The observation that most patients with cervical radiculopathy experience alleviation of symptoms with or without treatment is consistent with the results of small studies that revealed significant resorption in between 40 and 75% of cervical disc herniation. So this is another tidbit that's really interesting, is that most herniations of the cervical spine, thoracic spine, lumbar spine, they do reabsorb over time. And that is that's an important thing to remember when you're going for treatments. It's that the body does heal itself. So if you give it time, the body will heal. And I have patients that come in all the time, and they're worried about a disc herniation, that, yeah, disc herniation is bad. It's not good. But the real question is, why did that disc herniate? So it's not, the disc herniation is sometimes a symptom of what's happening there. And what I find is that, so if we look at the spine here, we have the cervical spine here going up, okay? We have the backs of the spinuses. So this is a lateral view. This is like the side. This is the jaw over here, okay? And these are the discs, these little purple things in the middle. And the nerves are these yellow things coming out on the sides. And then these little like stacked vertebra pieces here, those are called the facets. So when we talk about mechanical neck pain, these facets, if they're not lined up, if they're rubbing incorrectly because of misalignment or arthritis, they cause pain and they refer into a certain pain pattern. Discs here, they have a certain pain pattern, and they can be a mechanical pain. Now nerves, that's that nerve pain that we were talking about, that neurological pain. But these discs, they do reabsorb over time. And so the question is, why did they herniate in the first place? Why are they bulging? And what we often find is that the weight of the head is about 10 to 15 pounds. And if it's off center to the right or the left or the front or back, it places a lot of pressure down here at C6 and C7. And those are the two joints that most often they cause herniation down there, because the weight of the head is literally using them as a fulcrum, and it's placing more of the weight there than any other part of the spine. So it makes sense that C5, C6, C7 are the ones that herniate. And when they herniate, what you get is, if you have symptoms, that they tend to go into the fingers and thumbs here, numbness and tingling and burning pain into the thumbs and fingers. So you can tell that that's part of the problem. So anyways, these are just some tidbits about what's, neck pain, how it happens, and how we look at it. But a history is very important. That's something that we do in our office every time we go through. We do a full physical exam, because that physical exam is going to tell us a lot of information about what's happening in that neck. And then we also take imaging, and we do a special kind of imaging in our office. We do cone beam CT. It's a 3D X-ray, and that gives us valuable information that is you aren't going to get with a 2D X-ray, and that's a really important piece. And then in terms of outcomes, when we talk about randomized controlled trials and pain medications and therapies and things, there's a study here in one randomized trial that compared spinal manipulation or mobilization of the neck, like chiropractic or osteopathy, PT, home exercise and advice, and pharmacotherapy with NSAIDs or acetaminophen in acute and subacute neck pain. The manipulation and exercise groups fared better than medicinal treatment through 12-month follow-up. So that's really interesting, because, if you really take it for the long-term view, if we really hit it with some good mobilization and good stabilization of the cervical vertebra and the muscles in there, if we do some massage therapy and some chiropractic and get things lined up, the body can heal over a chance. And come check us out. We'll be at Atlantic Grill in Rye in February 20th, Thursday night at 6:30. Give us a call if you're interested in coming out, RSVP, and we'd love to have you there. Have a good night, everybody. We'll talk to you next week.